Hi and good evening, everybody. Thanks for tuning in. My name is Samar Aluri. I'm a consultant gastroenterologist and department head at the Medical City Hospital for Military and Security Services in Muscat, Oman. And it's my pleasure today to welcome a dear friend of mine, Dr. Nuru Noor, who is a clinical lecturer in gastroenterology at Cambridge University Hospitals NH Trust Foundation and the University of Cambridge. We met many years ago, and his passion in IBD has persisted over the years, despite some of the doubts that we had in the beginning that we might maybe shift careers at some point. Nora, welcome to Muscat Endoscopy Academy webinar series. Thank you very much for joining us today. And today we're going to be talking about optimizing treatment strategies in Crohn's disease. How do you feel about that?
Hi, Sam. Yeah, thank you very much for having me on. Yeah, really, real pleasure to be here, and yeah, really, yeah, delighted to talk about this topic, and yeah, very happy to answer any questions really about it. So yeah, as I say, great to be here, and hope to really cover as much as we can in over the next kind of 40 minutes or so.
Yeah, very nice, very nice. So Nuri, you've always been a guy that's very like analytical, and then you're very good at like, breaking things down. So I'm really excited about this. So we're trying to focus on today mostly is how to avoid common pitfalls at diagnosis and how to use early effective therapy to change the long-term trajectory of the disease. And you have been instrumental in some key publications on this topic of the last couple of years. My first question to you before we go into details, what drew you to this area of early Crohn's disease management, and what gaps in everyday practice did you want to address when you ventured into this?
Yeah, and I think so. Obviously, I started working in the field of inflammatory bowel disease with colleagues here in Cambridge. Well, almost about 15 years or so ago now. So initially met well, now both professors, James Lee and Miles Parks, who are gastroenterologists in Cambridge working on inflammatory bowel disease. And it really, you kind of, as with most things in life, you kind of fall into these things, right? There's no preordained plan, and so I started working with them. They're enjoyable to work with, and actually, the more and more we started working, we started focusing particularly on Crohn's disease and really trying to best understand how we could deliver the best outcomes for patients. And there's a variety of different things that we did, some laboratory-based projects, but I kind of quickly realized I wasn't that great in the lab, and so actually moved on more really to actually working more in the clinical setting. And I realized actually this is the thing I enjoyed the most, spending time with patients, helping patients to improve and get better. And actually then I really moved much more from lab-based research in Crohn's disease to more clinical research, and then around that sort of same period of time, we were actually developing a clinical trial called Profile, which I'll kind of talk about a little bit later on. And that took about 7 or 8 years to develop. As with all these big projects, they take a long period of time to deliver, design, deliver, and then there's still lots of work ongoing from that. So, yeah, as I say, it's been a long journey, really, not really pre-planned in any way, but really research and clinical work that's really focused on trying to help improve outcomes for patients with Crohn's disease, and it's something I'm kind of very passionate about.
Very nice. So following up on this, if we jump right into the topic uh, here, because I think a lot of us, like, kind of, as you said, we don't really pre-plan what the kind of academic career that we're going to do, and even sometimes a clinical one, especially the type of people that like to do both academia and the clinics and tie them together. But my feeling is that quite often many of the ideas that we get obsessed about are born out of certain frustration from within our own practice with something that we see happening repetitively, but that question or that gap in knowledge is not being addressed in a satisfactory manner. So And I think one of these things that you definitely have worked a lot on is diagnostic delay and why it still happens. So if we start with the diagnosis, I mean, despite better awareness nowadays about IBD and Crohn's disease specifically, delays remain one of the biggest problems, I would say. So what are the most common mistakes or delays you see when Crohn's is first suspected, and how can a clinician shorten that diagnostic pathway?
Yeah, I think this is such an important point, and I quite, as you say, I really like the fact that important research is actually things that are born out from, everyday clinical frustrations for patients, for clinicians, and actually how can we improve things. And I think one of the big things is often, we'll often see a patient who's, diagnosed with Crohn's disease, but actually when we start taking the history, when we're finding out more about the impact this condition has had on their life, actually we often develop Crohn's disease now that they're being diagnosed, but there's actually been a very long journey to them even getting to you as the clinician and having that diagnosis. And so there is this kind of thing that's been labeled as diagnostic, and actually it's a little bit hard to pin down exactly what is diagnostic delay, partly because there's no one thing that causes it. But there's lots of different factors, and we'll try and cover some of those if that's okay. So I guess the first thing is thinking about diagnosis of Crohn's disease. One of the common things that many clinicians will be used to hearing patients say is they say, do you know what, I've been saying to people that something's not been right for months, if not years. And often there'll be a statement that people say that they've not been listened to, or their worries have been kind of, unaddressed, or they've been told they have another condition. Now, often patients are told that they have irritable bowel syndrome. This is
Mm,
nothing to worry about. It's common, and this will pass. And in fact, there's a very large study that was conducted from the UK, from our colleagues in Nottingham, that showed actually a very large proportion of patients who go on to develop or have a diagnosis of Crohn's disease are initially labeled as having irritable bowel syndrome. So I think that's one of the big problems is actually having a misdiagnosis or an overlooked diagnosis, and this is one of the reasons why having I think greater awareness, education, and training is really important, not just for the clinical community. But we as gastroenterologists are obviously we're always thinking about bowel conditions and seeing bowel conditions. Whereas, for example, if a patient will present to their primary care practitioner, inflammatory bowel disease may not be top of the list of things that they're thinking about.
mm,
But equally, I think we need to increase awareness, training, and education for the general public, because actually, again, when people have bowel symptoms, they may often attribute this to, for example, irritable bowel syndrome, or something not, something I don't need to worry about. Whereas actually having increased awareness of conditions like Crohn's disease in the public might mean that we can reduce some of these diagnostic delays and people presenting.
mm,
And so when you think about delays, you can kind of think about there's the development of symptoms and then patients seeking medical attention. And there's lots of personal and social and cultural factors why someone may not go seek medical attention, particularly if some of these symptoms are a bit embarrassing, right? If you're going to having to rush to the toilet with loose stools, or even sometimes opposite, being constipated, or having these other rather non-specific symptoms, you may feel you don't want to cause anyone any burden or worry. So there are lots of factors that stop people from presenting to medical professionals or healthcare professionals early on, even after symptoms.
mm,
But then I think after that, there's also the diagnostic delay from clinicians recognizing that this could be Crohn's disease, arranging for appropriate tests such as colonoscopy. Then there's often the delay, depending on where you are in the world, of that colonoscopy taking place. Some places that might take place in days. Other places, you might be waiting months, sometimes even over a year, to get these, basic investigations performed. And then another delay then is even after an endoscopy or other investigations are performed, then seeing a clinician and having a diagnosis being made. So you can see why at every step of the way there could be diagnostic delay. And unfortunately, what we often see is that the vast majority of patients say that at every step there's been delay. So by the time patients come to us and they have a diagnosis, it's often been many, many months, if not years, of struggling on with symptoms to get that diagnosis. So that's something I think we can definitely improve all in every single country around the world.
Mm, mm. Yeah, I fully agree with you. I mean, from my experience, I mean, where I used to work before in Sweden and now where I'm working in Oman, there's the most of the patients that I have seen with Crohn's disease were not like, patients that just this is the first time they presented with like abdominal pain, let's say, or some obstructive symptoms or bloody stools and whatnot. Quite often, as you say, they go with for a long time, and sometimes in some cases they've had already some sort of irreversible bowel damage by the time they present, which is quite unfortunate. And yeah, so basically, what you're saying is you need to raise this index of suspicion, increase awareness in the public, and then once you are in that seat as a clinician, you need to make a comprehensive assessment and do the basics right. So I remember one conversation that I had with you once, and I don't remember which UEGW it was, where you told me that. When it comes to Crohn's, specifically, it's not just about finding, inflammation where people just start looking at the terminal ileum and then, if it's free, then there's nothing. But it's also about characterizing the disease fully and not just not just doing the colonoscopy to see if you find aphthous ulcers or not. So, in your opinion, how important is it to complete a full ileocolonoscopy with terminal ileum intubation and biopsies in every new Crohn's case. And your everyday endoscopist, how should they take those biopsies? How many jars? How many tests do they take them from right from the middle of that aphthous ulcer, from the sides of it? How deep should they go into the terminal ileum and so on and so forth?
Yeah, these are I think really important points. And I think the key thing is if you have a suspicion of a diagnosis of Crohn's disease, you really, I think, that patient, I think, really deserves as full an evaluation as possible. Because again, what we've seen historically is patients might have had bowel symptoms. They may have, for example, a flexible sigmoidoscopy. They're told that's normal. Or they might have a colonoscopy where the colon's, traversed down to the cecum, but there's no ileointubation, and they're told again your symptoms are due to IBS. This is not, and so forth. And so you can see why actually incomplete assessment can lead to missed diagnoses or overlooked diagnoses. So I
Mm,
think it's really important that for anybody with suspected Crohn's disease, we to perform a full ileocolonoscopy. And so then I think ileointubation is a must for all of these patients.
mm,
Now, I think this is really important because we know that about 30% of patients have only ileo involvement, and we know about in the 40% have ileocolonic disease. So actually, if you only look at the colon, you're going to miss a large proportion of patients who've got Crohn's disease. There's a smaller proportion who have even more proximal involvement, so it's proximal small bowel or even upper GI disease involvement. Typically, most international guidelines now say unless someone's reporting upper GI symptoms, they wouldn't routinely recommend gastroscopy. But if someone's also presenting with upper GI symptoms, then actually doing endoscopy from both the top end and the bottom end is now recommended by most international guidelines. And again, almost all the international guidelines, including those from ECHO, recommend full small bowel assessment as well. And so that might vary depending on what availability you have in terms of resources. In some countries, that might include an MRI scan of the bowel. In others, that might be an ultrasound scan of the small bowel. And in some places, particularly if there's no concern about stricturing disease, that might include videocapsule endoscopy or maybe a combination of those. But I think the key thing is patients who potentially have a diagnosis of Crohn's disease, they need a full assessment to determine do they have Crohn's disease or not. And despite all the advances in medicine, endoscopic examination is still a test to see if someone has active Crohn's disease.
mm,
You raised the point about ileointubation, and I think this is really key because it's a very common scenario that we'll see patients people will say, ileum intubated looks normal, or ileum intubated, what aphthous ulcers, and then you'll have imaging showing actually very florid, severe disease of the ileum on your MRI or your ultrasound. And then you have a little bit of a clinical conundrum, don't you? And you say, well, actually, the colonoscopy didn't look so bad. There was only one or two ileal aphthous ulcers reported on the colonoscopy.
Mhm.
I think this highlights the point that often ileal intubation, even we've said the importance of getting into the ileum, but I think there's a key then once you're in the ileum, you really need to get deep intubation. And
Mhm.
so what we often see, particularly I think this is the case in the UK, but I imagine this is quite a worldwide practice, is actually not very complete ileal examinations. And so actually just going in 2, 3, 4, 5 centimeters into the ileum probably isn't sufficient.
Yeah.
And by deep intubation, I think what we're really saying is you probably need to get at least 10 to 20 centimeters into the ileum to actually say you've properly assessed the terminal ileum.
Yeah.
Because actually, it's very difficult to make an assessment if you've only seen a few centimeters of the terminal ileum. Whereas, often when you go higher up, you can then see is there proper, mucosal wall involvement? Are there, big deep ulcers, or actually multiple smaller, more superficial or moderate size ulcers? So it's a common mistake that we see is that patients are labeled as having milder or moderate end of mild inflammation on the endoscopy, and actually all the rest of their objective findings are not congruent with that. They're actually suggesting much more moderate or more severe disease, and that's often actually because the endoscopic examination has not been as complete as it should have been.
Mhm.
I think your questions about biopsies are really good as well. So typically we'd say with ulcers, so the key thing is ulcers for both Crohn's disease and ulcerative colitis. It's, you can get lots of erythema and inflammation and areas of redness, but it's really the ulcers that we worry about, right? Because actually that's particularly in Crohn's disease where you have transmural involvement. It's those ulcers getting bigger and deeper and passing through the walls and through the layers, that actually you then have the risk of developing penetrating complications and things like that. So ulcers are really the key of a disease activity, and you really want to try and get biopsies from the ulcer. So typically we would recommend to actually get a sample of the side of the ulcer where you get a bit of normal tissue on one side and actually mostly ulcer on the other side. And so actually that gives the histopathologist a really good, I think, comparison of kind of normal to abnormal. Whereas typically biopsying the center of an ulcer is often not so helpful because again, you can get maybe more necrotic looking findings or very ischemic looking findings, but actually it's less helpful than that comparison with kind of normal tissue versus abnormal tissue. And I guess depending on where you are in the world, the other key thing about biopsies is it can help you exclude some of the key differential diagnoses. We
Right.
know intestinal TB is a big issue in many parts of the world. So I think increasingly we really would like exclusion of TB from biopsies because it can be quite difficult if you have someone with relatively short segment ileal involvement and ulceration. That can be very difficult to discern in some parts of the world from TB from Crohn's disease. So again, biopsies can be helpful as well as helping exclude some of the other infectious causes as well as other malignant causes as well. So I think all really good points, but I think in summary, a full evaluation is needed for all patients with a potential new diagnosis.
Yeah, I fully agree there. And it was like one of the things that I was, while prepping for this episode, like I had a suspicion, but that was confirmed actually when I was looking into this, is that in routine adult colonoscopies, usually, terminal ileum intubation is skipped in almost 50% of cases unless there's a specific reason. So it's like selective and not routine thing to do. And I think it's because usually like, maybe one important reason is like because the quality metrics drive behavior where units are just on cecal intubation rate and ADR, not TI intubation. So it gets skipped if the indication doesn't need it. And people do it only when they're being asked specifically to actually go in the terminal ileum. So, and maybe because there's a pressure on time, and if you're like you're inside the cecum with like 130 centimeters, and you have a big loop, then you cannot really get into the terminal ileum, or you just see you visualize the valve, but you don't really go inside to see what's in there. Uh, so in standard practice, quite often it's skipped, while in teaching units, usually they deliberately teach trainees to intubate terminal ileum, and there this rate drops apparently to skipping terminal ileum intubation only in about 15% of cases, which is still, I think, a lot, because what I was trained, I was told that colonoscopy is not a colonoscopy unless you've been inside the terminal ileum. So it's pretty, it was an interesting thing. I thought that people usually aimed for it, and I think this because the prevalence and the incidence of the disease is increasing, right, everywhere. I mean, I mean, Crohn's disease is not as rare as it used to be, and with better diagnostics, I think we have more and more patients, and because we have better therapies, I think we have a good chance of reversing the course of the disease, and we're going to probably be talking about this later on during this episode. So I think it's very important to point out for anybody who's working in a unit where, like, IBD patients frequent, which is pretty much every gastroenterology unit, it should be a part of the standard practice to go inside the terminal and have a look. I don't know what you do. Do you always
Yeah,
do the routine, or do you sometimes skip it?
yeah, no, I fully agree with you, Sam. And it sounds like we were trained by very similar people because certainly I had a kind of old school endoscopy trainers as well, and they had exactly the same phrase. That if you haven't intubated the terminal ileum, you haven't performed a full ileocolonoscopy, and they were very clear to call it an ileocolonoscopy procedure. And so when we consent patients, we actually put on the consent form ileocolonoscopy and make it
Right.
clear that actually this is routine for everybody. We go into the ileum. I would encourage this, particularly for any trainees listening, because actually, if you do this as a routine for almost all the patients that you see, then actually just getting into the TI every time becomes easier, right? And then
Mm,
actually, if you only save it for the patients where you think, okay, I've got a high suspicion that this is going to be Crohn's disease, then actually, if you're not getting into the TI very often, you're probably going to struggle more to get into the TI because you're not doing it on a frequent basis. So I
exactly.
completely agree with you. And indeed, I used to have a very old school trainer. And so if I went to the CECUM and didn't go into the TI and started making my way back, he'd
Yeah.
make me go back to the CECUM
Yeah.
and go
Yep.
into the TI because he
Yeah.
said, you
Exactly.
haven't
Yeah.
performed a complete examination.
Yeah.
So I think it's a very good habit. And as you say, it's probably a good training philosophy for us all as a field to have.
Mm, yeah. Very nice. Wonderful. So it's a nice segue into something that you were touching up on now, Nuru. It's about, like, beyond the colon, and like trying not to miss the hidden phenotypes. So I mean, even with a complete colonoscopy, some phenotypes are still missed. So you said we don't routinely do like an upper GI endoscopy, but my question would be here, when should we suspect proximal small bowel or perianal Crohn's disease, and how does that change our diagnostic and therapeutic approach?
Yeah, and I think this is a really important point because what we know is there's diagnostic delay anyway overall in Crohn's disease,
Yeah.
but for some of these, they're not rare, but let's say less common phenotypes, like small bowel Crohn's disease or perianal Crohn's disease, which is certainly not rare at all, and we'll come talk about that in a bit more detail in a sec. You know, the key thing is we know these patients seem to have even more delayed diagnosis, and the problem is that's then associated with worse outcomes. So it's really, really key for these, I guess, less common phenotypes that we kind of have, we kind of stay on high alert and have a low threshold to investigate and look for these because we know they're associated with worse outcomes and potentially they're more can lead to more complicated phenotypes as well. So for small bowel Crohn's disease, you can see why it is difficult because you could have a full colonoscopy that looks completely normal. you can have very non-specific symptoms, right? You can have someone who's got generalized abdominal pains. They might have a bit of weight loss, but actually weight loss is quite a late feature. So you may not have someone who has weight loss in the early period of having proximal small bowel disease. They may have some micro or macronutrient deficiencies. So you might see some, folate deficiency, vitamin B12 or iron deficiency. So again, thinking about why is someone nutrient deficient, and not if you don't have any obvious cause,
Mm.
wondering could this be small bowel involvement of Crohn's disease. But I think it's difficult because actually the symptoms are very non-specific. But
Mm.
if you've got any of those things, abdominal pains, anemia, nutrient deficiencies, weight loss, etc. Let's say you've got a high index of suspicion for proximal small bowel disease. As I said, there's a range of investigations you could do. MRI's probably got the best, I think, kind of overall scan. Obviously, you probably want to avoid because of radiation, but there is a lot of emerging evidence for video capsule endoscopy. And now that's quite widely available in some parts of the world, in other parts not so widely available. So it depends a little bit on what resources you have. But I think video capsule or MRI for most people. Now, small bowel endoscopy is obviously very limited, very precious resource, only going to be available in very select specialist centers that can do enteroscopy. But you do sometimes, if you absolutely want tissue, you
Mm.
should do sometimes see small bowel enteroscopy being performed as well. But I would say that's probably the least common investigation.
Mm.
Um, and then similarly for perianal Crohn's disease, you have to remember this is quite an embarrassing area of the
Right.
the bowel. If the bowel is embarrassing enough, but the perianal area is very embarrassing, it's not something that you would normally bring up in consultation. And
Right.
so actually I think this is really where we as clinicians, we have to directly ask about these things,
Mm.
because actually I've seen patients who've been seen by 4 or 5 times before by other clinicians, and then I ask them directly about perianal symptoms, any pain, any swelling, any redness, things like fissures, fistulae, etc. And actually, you'll be amazed by how many patients will say, yes, I do have those things. And
Mm.
then you go and examine them and they have very clear perianal Crohn's disease, maybe even fistulizing disease. And
Mm.
actually, when you say, how long have you had this? They say, well, actually, I've had this for, you know, all of those previous consultations, but I just felt too embarrassed to bring it up. I didn't think it was relevant. I wasn't sure this was linked to the bowel or not. So I
Mm.
think we really need to have a high index of suspicion, and we need to ask about perianal features of Crohn's disease, because it's not something that patients often will willingly volunteer,
Mm.
because it's not immediately clear sometimes that actually an abscess near your perianal region is actually related to Crohn's disease.
Yeah.
It's obvious to us as clinicians, but a patient might think unrelated to this inflammation of the tract. Now, the reason I think it's important to have this high index of suspicion and specifically ask is we know these can give rise to more complex phenotypes and have a really devastating impact for patients if they're not well controlled. And we'll all have seen really severe cases of perianal Crohn's disease where you wonder, well, actually, if the diagnosis had been made much earlier, and actually if intervention had been made much earlier with either medications or surgery or both, maybe we could have led to better outcomes for that patient. So I think really need to, screen for these things. And again, in terms of investigations, kind of the go-to nowadays for perianal disease would be an MRI scan of the perineum to help delineate perianal disease. But this is another, and we'll come back to this a bit later on, but this is an area where close working with our colleagues in surgery can be really helpful, because again, a combination of an MRI scan plus an examination under anesthesia can often help delineate, particularly fistulizing Crohn's disease, how
Mm.
many fistula tracts are there, what's the anatomy of those tracts, and actually do you need a combination of medical or surgical approaches. So I think the reason why it's so important to pick these things up is actually because the management can be a little bit more complex, and so
Mm.
you really want to pick it up and detect it as early as possible.
Mm. Mm. Yeah. Amazing. Absolutely fantastic. And I could not agree more with everything that you were saying there. And like, when you're saying it, no, it's just like it's just so logical and makes a lot of sense, right? But I mean, we both see in the clinical practice that like a lot of these things, they just go under the radar for a very long time. I mean, the number of times that I have unfortunately seen patients treated for an anal fissure for multiple years, different with different like, ointments and whatnot. But like, it ends up in the end, it was actually never a fissure, but it was actually a fistula. And once you start asking these patients about other symptoms, you start like, pieces start falling into place that this actually might be, IBD, that is, or Crohn's disease, that is the culprit here. So, absolutely great. Fully agree with you. And this goes back to like this thing was like if you need to make this kind of a holistic assessment, right? So if we move beyond inflammation a little bit, uh, I mean, there's a holistic care here. Like, the Crohn's disease is a systemic illness. So it does not affect only the bowel, it affects in nutrition, mental health, and quality of life. So, in 2025, like, how can we better integrate nutritional, psychological, and even extraintestinal aspects into routine Crohn's care? And is it being done?
Yeah, this is a big question, isn't it? Because you kind of three different elements. So kind of, as you say,
Uh,
there's the bowel element, but there's all the stuff outside of the bowel, which is all
yeah,
linked. And so I'm going to kind of split those into three. So you mentioned about the non-gastrointestinal manifestations, and we know that about a third of patients have typically skin, joint, or eye involvement. They're the kind of the big three
mm,
extraintestinal manifestations. But
yeah,
actually, you can have involvement of basically any symptom in the body. So you can
yeah,
have involvement of the liver and the biliary system. There's certain conditions that are associated with both Crohn's disease and colitis and the hepatobiliary system, particularly thinking about PSC and
right,
IBD.
right.
People typically more PSC and UC. You can
Mm,
also have involvement of the brain, the heart, the lungs. You know, the list kind of goes on. But as I say, skin, eyes, and joints, they're kind of the big three.
yeah,
And so I think one of the key things is we need to screen things because it's not immediately clear. I mean, if I was a clinician, it wouldn't immediately be clear to me as a patient that actually my painful red eye might actually be linked to my bowel.
yeah.
And so I think we need to screen for these extraintestinal manifestations. And actually, what we know is typically inflammation or treatment that treats the inflammation often helps resolve or reduce these extraintestinal symptoms. Typically, not always. There are some that are a bit distinct from the inflammation of the bowel, but most of them go in line with inflammation of the GI tract. But
Right.
actually, I think increasingly now we're working with our colleagues in these various specialities. So actually, in the olden days, we might have just started treatment and said, look, if we treat your bowel, then your joint and skin symptoms should improve. We hope. Let's see. Whereas actually nowadays, I think we're saying, well, actually, you know, as part of our holistic care, we really want to manage and give this patient the best care possible. And actually, we're now often managing these patients alongside our colleagues in rheumatology if there's joint manifestations, or alongside colleagues in dermatology if there's skin manifestations, etc. And equally, if I had someone with an ophthalmic manifestation, or I thought might be an ophthalmic manifestation, I'd often ask my ophthalmology colleague to see. So I think working together as a teams, I think generally is a good thing to do anyway. It means you provide better medical care, but also it means that the patient receives, I think, more holistic and better overall care, and it's not everything just focused on the bowel, so to speak. I
Mm,
think you raised two other really important points, and we know for many years we've known there's a link between the gut and the brain,
right.
this gut brain axis. And there is absolutely no doubt that there is an association between Crohn's disease and both anxiety and depressive symptoms,
Mm,
as well as other mental health symptoms and
yeah.
such. But particularly anxiety and depression, or I should say depressive symptoms. Now, one of the key things is that historically that was always thought to be a one-way relationship, and that if you have active inflammation, that's going to make you feel, more tired. That's going to give you a lower mood, make you feel anxious, and so forth. Actually, what we're realizing now is it's almost certainly not just a one-way relationship. It seems to be a bi-directional relationship,
Mm,
as with all these conditions of the gut and the brain. And so, actually, not only does active inflammation make these symptoms worse, but actually having presence of anxiety and depressive symptoms seems to be a modifier and help actually make the Crohn's disease worse. And so
Mm.
actually you highlight a really important point. Just treating inflammation and hoping that actually the mental health symptoms get better, I think that's maybe what doctors and clinicians used to do in the past. Now we're
Mm.
realizing that's probably not good enough, and we need to take a much more holistic approach to that. So, yes, we do need to treat the inflammation, get symptoms controlled and better, but actually, equally, from the mental health point of view, we need to see what the key symptoms are. As I said, is it anxiety? Is it more kind of obsessive compulsive kind of type disorder? Is it more depressive symptoms? Is it a mixture of those things? And obviously the different personality types will have an impact. And actually there's various different interventions that we can make, particularly psychological interventions that could help. And so one of the things that we're seeing many IBD teams around the world now increasingly implementing or thinking about implementing is actually having psychological support for their patients
Mm.
with not just Crohn's disease, but with IBD in general and with a range of gastroenterological conditions. So we're quite lucky in my center in that we have an IBD specificist. So when patients are newly diagnosed with Crohn's disease, not only do we treat from a medical point of view, but we also offer all of our patients to see a psychologist to actually try and help address some of those bidirectional effect from the psychological symptoms and see if we can. It's important to note that I said the word offer because not every single patient wants to see a psychologist. And
Yeah, yeah,
indeed, I've had
true.
I've had many patients where I said, "Look, we have a psychology service available," and they've said, "I don't want that. That's not." But I've
Yeah,
said, "That's no problem. I just want to let you know it's available if you ever feel that's something that you might benefit from." And equally, we've had other patients say, "I'd really love." That service. I'd really like to take you up on that offer. So I think with all these sort of these services, when you're thinking about implementing them into your hospitals, it's worth bearing in mind there's no one size fits all approach. Not everyone's going to want to see a psychologist. Not everyone's going to need to see a psychologist. But if you have that service available, I think it's a great service actually, and something as I say. I have no doubt the quality of care we've been able to deliver to our patients locally has got much better as a result. And I think the third thing you mentioned was about nutrition and
right.
diet. And
Mm.
again, these are all three very big topics in themselves, aren't they? But I guess it's important to highlight you're absolutely right. Dietary assessment, I think, and nutritional intervention is key because we know most of our patients, when they're newly diagnosed with Crohn's disease, are often malnourished. We've
Right,
talked about the fact they've often had uncontrolled active inflammation building up for months, if not years. So it's
right.
perhaps no surprise that people are going to be malnourished, have nutrient deficiencies, and so forth. So again, it's a routine that for all of our patients who are newly diagnosed, we offer them the opportunity to meet with one of our specialist dietitians, and we try and implement nutritional interventions alongside appropriate medical therapy as well. So
Mm.
quite a lot there, but I've hopefully just sort of summarized a little bit exactly your point. There's a lot more to Crohn's disease than just the
Mm.
bowel and the gut, and
Yeah,
we really need to think about everything and holistically giving that patient the best possible care.
amazing. I think we can do a full episode just about like these things because there's so much there to unpack. But we should talk about the other big stuff that is very intestine, let's say, related. But Noor, all right, Noor. So great. So if we now move on to let's say let's call them therapeutic mistakes and what to stop doing. So one of your papers highlights some of the persistent mistakes in Crohn's treatment, particularly over-reliance on steroids and mesalazine. So, why do you think mesalazine and long courses of steroids are still used so often despite limited benefit in Crohn's disease?
Yeah, this is, I think, a really important question, kind of the eternal question, right? Isn't it?
Right?
Why,
Yeah.
when we have so much evidence, why is it that so many people around the world don't kind of stick to the evidence? I think the main reason is that people kind of think they're not doing harm, right? They're kind of you're using not a very effective treatment. You're not going to cause any harm, and that's why often people say, "Look, I'm going to prescribe mesalazine. It may not do great but it may not do any harm. And that's the historical thinking behind using, because that's kind of how it's used in ulcerative colitis, a base medication, and if that doesn't work, you go up. And so that's, I think, why historically people have similarly tried to use it in Crohn's disease.
Mhm.
And equally, people think about steroids. Well, look, I'll just give a course of steroids. It will just be 2 months, get the patient feeling better, control the inflammation, and then then they'll be off the steroids. I won't, I'm not doing any harm. That's what people think. The problem with that is we know the vast majority of people with Crohn's disease, it's this chronic progressive condition. So actually, by not appropriately treating patients, not appropriately getting that inflammation under control, we're allowing that disease to progress. And
Right.
so actually, it's a little bit of a mind change, right? The psychology is a bit different, but actually, by not treating properly, we're actually causing harm.
Mm.
And so the main reason people, I think, don't use more effective, I guess, more potent immunosuppressions, and we're going to talk about those in a bit, like biologics or small molecules, is I think people have said, look, I'm not going to do any harm by just using mesalazine or only, using a course of steroids, as and when needed. But actually, it's the disease progression that's being allowed to happen. That's the harm that's happening. And so actually it's important to highlight mesalazine. There was a big Cochrane review back in 2016, and it's one of the most striking conclusions you'll ever see in any paper where they say there's absolutely no evidence of benefit for mesalazine in Crohn's disease.
Uh,
And they actually finish that they have a sentence saying there's no need for any further research in this question. They go, it is done, And so
yeah.
it's really one of the most striking things that we have absolutely clear evidence and clear guidance that we
Yeah.
shouldn't use mesalazine in Crohn's disease, and
Yeah.
yet people still seem to do so. So that's, I think, one of the big mysteries of the world. And I think with steroids, I think some people have been satisfied that as long as we all recognize long-term maintenance steroids are a bad thing, right? I don't think I need to convince anyone that that's a
Yeah.
bad thing. If you're on steroids for years and years, you're going to have bone fractures, weight gain, you're going to get Cushing's, all the sort of diabetes. There's no doubt that's a bad thing. But the repeated courses of steroids, actually, there's increasing evidence this is equally a bad thing, because there's not just the disease progression I've mentioned. Actually, there's still going to be the osteoporosis, all those complications associated. So actually, under treating Crohn's disease with mesalazine or repeated steroids is absolutely the wrong thing to do. I think in 2025, we can now say that absolutely categorically. And what we need to do is try and help the clinical community to try and move away from that sort of
Mm.
practice, which, because as I said, the evidence now is overwhelming that that's the wrong thing to do.
Yeah. Yeah. I fully agree there. And it's as you said, like, I mean, you see this like globally. It's this like they kind of like Crohn's disease and UC are kind of linked together and like treated interchangeably, while like, I mean, they're quite different disease phenotypes. So it goes back to really like having this kind of chats like the one that we're having right now to outline the subtle differences between those two diseases, but that can mean a lot for the like the prognosis and the future progress of this condition. So if we now shift gears and we go to what works, so early effective therapy and the window of opportunity. So this concept of window of opportunity for early treatment has gained real traction in the last couple of years. So, what defines that window in Crohn's disease? Would you say, and what's the current evidence that early biologic or advanced therapy truly changes disease course?
Yeah, this is, I think, a really important point. And so, actually, you said it's gained a lot of interest and traction in the last couple of years, and you're absolutely right. But actually, the window of opportunity was kind of proposed in Crohn's disease about 15 years ago, the concept. And so, it's whereby you have a window of time, usually early in the disease, where you could maybe reduce or prevent that propensity to develop complications. We said most people are on that chronic progressive disease curve. So maybe if you intervene early enough, you could actually reduce or even prevent some of those complications from occurring. And that's kind of been the kind of theoretical basis for the window of opportunity. But as you highlight, one of the big questions has always been, well, actually, what is the window of opportunity? How early is early? So historical studies, if you go back 15, 20 years, actually the bar was actually not set quite high. So actually early intervention used to be considered years, sometimes even decades after diagnosis. And actually, if you tried to start a biologic at any stage, that was kind of considered early. We then have had actually, I think, quite seminal studies that really, I think, kind of began to question that. So if you look at the original Step Up Top Down trial that was led from the Netherlands, they defined early disease as less than 4 years after diagnosis. What they did is they gave people 3 doses of biologic therapy, and then there was no maintenance therapy arm. And you might say, well, why was that? No, nobody really knew how to use biologic therapy back then, so everyone was kind of still finding their feet. But what we saw was that there was a definite signal for benefit for patients who
Mm.
received 3 doses of biologic. But
Mm.
because there was no maintenance biologic therapy arm, there was no benefit or no difference seen between the arms over time. So a signal that early treatment might be a good thing, but it was just a signal, didn't change practice. I think then there's a really seminal trial called Calm, about 8 years ago that was published. And that in Calm, patients were treated about 1 year after diagnosis with anti-TNF. And in that trial, it was adalimumab. And you could actually really good outcomes for patients with Crohn's disease. And in fact, at the time, they were the best that had been reported in Crohn's disease. And so that was treating patients 1 year after diagnosis. So better, but actually still room for improvement. More recently, we've seen data that if you use biologic therapy in the first year of diagnosis, that's associated with even better outcomes, including things like transmural healing and less complications.
Mm.
We actually conducted a trial called Profile from the UK that I know you and many of your listeners will be very familiar with. And so in Profile, we actually treated patients newly diagnosed with Crohn's disease within days of diagnosis. So
Right.
this was by far the earliest early intervention trial in Crohn's disease.
Mm.
And what we saw in Profile was actually even better outcomes. So we actually had the highest reported rates of remission from any clinical trial in Crohn's disease. And that was a kind of a composite of both symptoms and biochemical inflammatory markers, so CRP and calprotectin. But you
Mm.
might say, well, actually, there's still an element of subjectivity there. What about something more objective? What about harder? Something like endoscopic remission. So most registrational trials in Crohn's disease, you typically see endoscopic remission rates 20, 30% at
Mm.
best. What do we
Mm.
see in Profile? Well, we saw that at the end of 1 year in Profile, 67% of patients who received biologic therapy as soon as possible after diagnosis, and for us, we were using anti-TNF, could achieve ulcer-free endoscopic remission. So overnight, double the endoscopic remission rates that we've seen reported in any other Crohn's disease trial. And so what we've seen is actually by going as early as possible, so as soon as you can after diagnosis, you can really deliver the best possible outcomes for patients. So I think your question about what is early or what is the window of opportunity, well, I think now what we know is it's not years, it's not decades after diagnosis, it's probably not even years or months after diagnosis. It's probably days or even weeks after diagnosis. That's the sort of time frame we should be thinking about. And actually, if you look at the rheumatology literature, our colleagues have been saying this for decades for
Yep.
rheumatoid arthritis, that if you present with rheumatoid arthritis, you have weeks, maximum 3 months to try and get this patient onto an effective therapy to control the inflammation, prevent the joint damage, and prevent permanent joint destruction. And so I think we really need to think much more like our colleagues in rheumatology about the need for urgency for treatment.
Yeah, yeah, absolutely. Yeah, I think we always lag behind in gastroenterology there, and I think because maybe in rheumatology the presentation is maybe more acute and less subtle than that. So an intervention really shows quick, like shifts in in like nature of the disease. So I fully agree with you there. And I think profile was like really landmarks there because I think it reminded us that like it's like not one size fit all. Some patients respond to early biologic therapy. Others may do well with conventional induction, but the lesson is about precision medicine and risk-based decision, right? I mean, it's just, and I think you just published a very nice paper in Journal of Crohn Colitis about also the incremental gain and or incremental amount of savings if you do the top-down approach versus top-up, right? And it was showed that if you actually do that, you are actually not only determine improving the disease course or shifting the disease course for the patient, but you're also it's from the health economics point of view, you are actually doing the whole society a favor, right?
Yeah, exactly right. And I think historically, that was one of the concerns. If we use these medications very early on, are we just going to bankrupt our healthcare services? Because, they historically were expensive medications. I think it's important to note that particularly for anti-TNF, and now we have ustekinumab as by a similar introduction has completely dropped prices medications, really increasing availability or widening access for patients. And exactly as you highlight, what we showed in the formal health economic analysis from Profile is not only is this the more effective and actually safer treatment strategy for patients, but when you look at costs and benefits, actually all the costs of drug and costs of infusions, they're completely offset because you control the disease. So you reduce disease flares, you reduce visits to GPs, you reduce hospital admissions, you see a massive reduction in the need for abdominal surgery. And so all of those things overall mean you actually save money for healthcare services by
Mm,
controlling and treating inflammation as effectively as possible, as soon as
mm.
possible.
Absolutely. Absolutely fantastic. And this is like kind of the shift from like this like short-term kind of solutions to kind of long-term vision of
Yeah.
for like patients and like for society as a whole to try to think about that and not think about like only what it's gonna cost us in terms of our budget for this year, but maybe the incremental gain over the period of 10 years. But I think this is kind of something that kind of the administrators of the hospitals should actually look into because I think if you leave it to clinicians, we would probably be opting for things that would actually help patients and save money in the future. But I don't think everybody sees it that way, right? So fully agree with you there.
Yeah,
Um,
you yeah. It's really important to publish this sort of data because, as you say, we as clinicians can see the benefits of the interventions, but many times administrators or those responsible for reimbursing, understandably, all they can see is the cost,
mm,
right? The cost of
mm,
drugs, the cost of infusion centers. So actually, if we can present the data showing, yes, there is the upfront cost of drug, but
yeah,
actually look at all the savings down the line, that's what they need
yeah,
to see as well. So I think we as a community, it's kind of on us to provide that information to them.
yeah, exactly. Yeah. Um, And now if we shift gears into surgery a little bit. So surgery still has a place in modern Crohn's management, even when we have all the fancy biologics and small molecules and I mean and like the lexicon of these drugs is just growing bigger and bigger. I can hardly keep up anymore. When should we consider early limited surgery and how can medical and surgical teams collaborate better because sometimes it's not always working perfectly. So what's the magical recipe here?
Yeah, this is. I don't think I've got the answer to what the magical recipe is, but I think it's a really topical point because certainly we know there's a lot of evidence now that if you have short segment of just inflammation localized to the terminal ileum, those patients do very well just having a localized ileocecal resection. And we had the Lyric trial actually many years ago now, led from the Netherlands, but actually multiple observational studies essentially validating those findings. And we know actually that if you have short segment terminal ileal disease, those patients can often cycle through multiple biologics or small molecules before we ever get control or actually before they proceed to surgery. So there's absolutely a group of patients who I think may benefit from early surgery. Now, there's a couple of issues there. Obviously, what do we define as early surgery? Well, historically, that was surgery or biologic, but that was often years down the line for many patients. But
Mm,
we've just said actually now, when you look at studies like Profile and other similar studies that have replicated findings, we're now saying early treatments from the point of diagnosis. And so one of the things is, are many patients ready to discuss or want surgery so early on in the disease course? That
right.
depends quite a lot on the individual personality, societal differences, cultural differences. But often, and I'm sure you'll have had it, and I'm sure many of your listeners would have had it as well, the first thing patients say to me when we diagnose them with Crohn's disease is, I really don't want surgery, or the one thing I really want to avoid is surgery. That's
Yeah.
often the first thing patients will say.
Yeah.
And I often try and kind of allay those fears and actually say, actually, sometimes surgery can be a good outcome. And actually, exactly the discussion we've just had. If you have short segment terminal ileal inflammation, actually, some surgery might even be the best treatment option here, right, rather than medications. But
Yeah.
it's very difficult because if patients, I think psychologically it can take a while to even be comfortable with the idea about discussing surgery or even thinking about surgery. And
Mm,
so for some patients, even if they might be a good phenotypic candidate for surgery, they may not want surgery. They may want to try medication treatment options. Equally, there may be patients who are the opposite and they're very keen to meet a surgeon, discuss about surgical intervention. So I
mm,
think this is really where a personalized, individualized approach is important. The second thing, and I have to say this is a big challenge for us in the UK, is surgical capacity and surgical
right.
availability.
Yeah.
And so what we see is around the world, there are not actually that many colorectal surgeons relevant for the relevant size of populations in terms of pathologies. And there are even fewer IBD specialist colorectal surgeons in pretty
Yeah.
much every country around the world. And so the thing is, when we as gastroenterologists are seeing these patients and newly diagnosing these patients, let's say we have someone with short segment terminal inflammation, and let's say the patient is open to the idea of surgery and quite keen to discuss the possibility. The big problem I think we have in the UK and in many countries is then having enough surgical capacity and resource to actually even being able to offer early surgery to those patients,
Mm,
because
mm,
actually in the UK the elective surgery waiting list is over 1 year. And
yeah.
so even if a patient wants surgery and we think they'd be a good candidate for surgery, our surgeon might say, well, I can offer you an operation in a year's time.
Yeah.
And obviously we can't leave the patient untreated for a year. And
Yeah.
so I think there's some major capacity and resources issues that limit or preclude early surgery, even for patients where it might be a really good option.
Mm,
And I think this is really where we need to advocate for more colorectal surgeons, more IBD specialist surgeons, and to
mm,
try and increase capacity. And I think, yeah, I think we don't do it locally, but I've heard of some places where actually newly diagnosed patients or people early in the disease course would often meet a gastroenterologist and a surgeon and have these discussions in joint clinics. So I think it's a great idea, but I think you need to have the capacity to offer
yeah.
early surgery to be able to offer that sort of thing.
Yeah. And that's definitely right. Yeah. And the waiting time, I think in Sweden was almost more than probably 2 years for something like this. So I fully agree there. Um, let's say we have a patient that we've treated, started treatment, and we are at the stage of monitoring. So it's like the stage where just like it's just as important as the initial therapy choice, I would say. So how can we practically implement this treat to target approach in real world settings, and which markers are most reliable, would you say?
Yeah, and obviously we're all familiar with the STRIDE guidelines. There was STRIDE 1, more recently STRIDE 2, and currently STRIDE 3 being developed, whereby we're kind of recommended to develop short, medium, and long-term targets with our patients. And I quite like that concept, right? And so typically you might set a short-term target of, trying to get clinical response, feeling better. I have a medium target of trying to, I don't know, let's say normalize inflammatory markers, And typically, most of us are using fecal calprotectin in our clinical practice. I appreciate in some parts of the world that can be difficult to get reimbursed, but that's what most clinicians I think are using nowadays. Or although ultrasound I think is of growing interest as well to many people, and sometimes combining ultrasound with fecal calprotectin. And then long-term targets are typically aimed at trying to ensure kind of good quality of life for patients. So I quite like the framework that Stride gives of short, medium, and long-term targets. The problem with these sorts of guidelines and is that sometimes they're seen as rules, and so when you've got recommendations for things like endoscopy, and in the future we might see recommendations for histology
Yeah.
and ultrasound. A lot of clinicians say, well, I'm not going to do that. Or I don't want to do that. Or patients say, I'm not going to do that. I don't want to do that. And I think the thing we have to realize is these are just guidelines. They're not rules. And so we need to adapt our short, medium, and long-term targets for each individual patient. And so typically I do use that stride guidance, but I'm actually very individualized in terms of what the target for each patient is. And so actually, if someone, as you kind of mentioned, if they've had one biologic therapy, I might have a very quite stringent targets that we're going to aim for. We want biomarker normalization. I want that patient to have as good a quality of life as possible.
Yeah.
But actually, if somebody's had five biologic or small molecule and or small molecule therapies, and they've had multiple intestinal resections, actually what you can achieve and what your targets might be a lot more relaxed than for someone else who's, say, bio-naive and very early in the disease course. And so I think there's no point setting an impossible or unachievable target and actually pushing towards getting a normal fecal calprotectin for someone who's gone through five biologic therapies and has never had a normal fecal calprotectin. Actually, for that patient, you want to try and set a more realistic and achievable target, and actually one that they want to achieve, because actually you need buy-in and I think agreement from and direction from the patient for what these targets are. Because actually, what I've seen is sometimes people set calprotectin targets, and then you've got patients who don't provide any stool sample for 5 years. And so
Yeah.
actually, there's no point setting a calprotectin target for people who actually don't want to provide a stool sample or actually find it very difficult to provide a stool sample. So you have to set a target that's realistic and
Mm.
actually is very much in keeping with the patient's own preferences and what they'd like to aim for as well.
Mm. Yeah. Yeah, exactly. Yeah. It's really it's very satisfying for a clinician to follow a patient's journey from the time of presentation, especially with complex disease, to the point when they're like, in full remission. But the reality is quite often is that when we get those patients in remission, it's like short-lived because of like a lot of these things that you're talking about, where maybe we meet the short-term or the medium-term target, but we don't meet the long-term one, or we meet the long-term one and then they just fall off the wagon, let's say, and just we're back to square one. So it's not very easy, but I think with some sort of structure and like, guidance, probably we should all aim towards like kind of try to do the same, or not the same approach, but follow a similar approach to our patients so that we ensure that they're all treated pretty much like in a way that is according to the latest state of evidence. Because I mean, looking ahead, you mentioned this importance of tailor therapy and the importance of precision medicine. So now 2025 is almost over. So what does personalized or precision therapy mean in practical terms for patients with Crohn's disease today?
Yeah, this is, I guess, one of most overused terms in IBD, isn't it? And like I think the whole of medicine, we've been talking about it for well, over a decade now. It's been in the literature for over 2 decades. I think if you look at the definitions, you'll often see things like the right treatment for the right patient at the right time. These kind of slightly nebulous sounding terms. Actually, for me, I think it's just a really simple way of thinking about personalized medicine is, what's the goal of the patient? What do they want to achieve? And actually, what can we do to help them get there? And then that's actually probably the best way to think about it. And so, honestly, I think in the past, when you talked about precision and personalized medicine, people would often say stuff like, some sort of sexy molecular test or tool to try and predict X treatment or Y treatment. I think increasingly we're kind of moving away from that and recognizing that might actually not be what we want to achieve or aim for as a field. That might actually not be what most patients want. Most patients actually, if the goal was to feel as better or as good as possible and have as good a quality of life as possible, then increasingly what we're realizing is actually a bit like you mentioned with early effective therapy and tight control and the treat to target approach. There is this concept of mouse personalization, where
Yeah.
actually, if you can get the best possible outcomes for as many people as possible, that's actually going to be a more effective approach. It's still personalized, but what we're not saying is you're not having some sexy molecular tool telling you that these genes are abnormal and hence you must use X treatment. We're actually what's saying is it's the more subtle approach, the kind of more clinical finesse to
Mhm.
personalizing treatment, and actually using what we know and implementing that actually results in the best care for patients. And actually, we know we can deliver really good outcomes for many patients with Crohn's disease if we just instituted some of the things we talked about today: early diagnosis, early treatment, early tight control, and the kind of treat to target approach. And so
Yeah.
that's really this concept of mass personalization that
Yeah.
increasingly I think we're seeing more people publishing about and kind of writing about. And increasingly, I think that's where we're heading as a field as well.
Yeah, absolutely fantastic. Yeah, so this last post that you were saying is was making some notes during the episode, like about the things that I like, the pearls, let's say, of the things that you've been talking about in terms of. I mean, there's no such thing as like, a one size fit all, and like this precision medicine is definitely overused. Everybody talks about it, but few people follow it because, I mean, there's so many hurdles and obstacles to like tailoring a therapy to every single patient that walks through the door. Just there's no time constraints, budget constraints, and even like, sometimes knowledge constraints. I mean, it's not that easy to keep up with everything that is out there, and to have it like available to try, because you may read a paper that says that drug A will give you result X and disease Y, but if you don't also try and yourself and see how it works in your setting, you'll never know. You wouldn't believe it. Seeing is believing, right? I mean, that's I think something that's just correct across the board, regardless which disease we're talking about, right? So, some of the things that I've learned from you today here, that I think if somebody were to take home a few messages from this, is like people need to have a good index of suspicion, diagnose early and completely, and do a good ileal and small bowel assessment, during a high quality ileocolonoscopy, and avoid steroids overuse and mesalazine dependency, and escalate appropriately, right? And try to do it in that window of opportunity, and try to maintain this treat to target mindset by using like objective monitoring methods, and collaborate with your colleagues, surgeons, nutritionists, psychologists, and sometimes even like, GPs, because they meet those patients for other things, other aspects that might be connected to the disease, but the patient wouldn't know about them, right? So, this is absolutely fantastic. Have I missed anything from that listeners should definitely be thinking about?
No, I think you've got it all there, Sam. I really like your take-home messages. Yeah, I would just echo all of those. So yeah, early recognition, early diagnosis, early effective treatment, and then monitoring afterwards. I think these are the key things. So these are the basics, right? As in every single clinician in every country around the world, we can do these. You don't need any sexy molecular genetic tests to do this. All of us can do this right now today.
Yeah, perfect. Absolutely fantastic. Noor, like, you are definitely you master of your craft, and I've always enjoyed speaking to you about like scientific and nerdy stuff. And also like when we talk about things that are unrelated to medicine. So thank you very much for your time and your effort today. And I really hope to host you again on another webinar in the near future to talk about the other big elephant in the room, which is ulcerative colitis. It would be a great honor to hear your insights on this. Thank you very much, Nuru. I really appreciate it. I wish you a great evening ahead, and congratulations on your wedding with the small wedding with 500 people.
Thanks very much. Thank
All
you.
right, man. Thank you so much. Have a good night.
You too. Take care.